This is Susan Clinton. I'm the instructor for the Pelvic 3 course at Brooks. And this PowerPoint movie is going to be an overview of irritable bowel syndrome and inflammatory bowel disease. As we discussed in Pelvic 2, one of the things that we always want to do is our differentials to make us understand to help us understand when medical management is necessary. So we always want to look to red flags. If you have people with GI disturbances or dysfunction, some of the red flags are going to be weight loss greater than 7 pounds without them knowing why they lost weight, difficulty swallowing, repeated vomiting. If they appear to have a fatty stool or they report changes in their stool, such as fat globules noted within the stool, a recent change in bowel habits. They started suddenly having uncontrollable diarrhea, or for some reason they've become significantly constipated without knowledge why. If they have significant abdominal pain, anorectal pain, anytime there's anorectal bleeding, that should trigger a referral back to the physician to find out why. If they have continued nausea, vomiting, cramping, they don't belong in your clinic. They need to seek medical solutions. Are they sick? Do they have a fever? Did this suddenly begin to happen for them in their older age? And does the problems wake them up in the middle of the night? And do they have a history, or do they have a family history of cancer? By definition, functional bowel disorders are functional gastrointestinal disorders that have symptoms attributable to the middle or lower gastrointestinal tract. Make no mistake, these are not diseases, so to speak, but they are motility and transit disorders of the lower and middle gastrointestinal tract. Classification of functional gastrointestinal disorders include irritable bowel syndrome, which we'll be talking about today, and also functional bloating. These also include functional constipation, functional diarrhea, and unspecified functional bowel disorder, which were covered in Pelvic 2. Part of your readings for Pelvic 3 includes the Rome criterion for understanding bowel disorders, and the reading that I have posted is for irritable bowel syndrome. We need to know when to label a bowel disorder as a functional bowel disorder. And generally, it falls into categories of the symptoms must have occurred for the first time greater than 6 months before the patient presents. And their presence should be on greater than 3 days a month during the last 3 months. So in other words, it must have been going on for about 6 months, and it needs to be occurring pretty much at least half a week during the last 3 months. IBS is a little bit trickier because it's a functional bowel disorder in which there is association with abdominal pain or discomfort along with defecation or a change in bowel habit. In other words, if there's abdominal pain before defecation, or if it begins to change between constipation and diarrheal type defecation along with abdominal pain, that's going to be considered irritable bowel syndrome. This slide begins to discuss some of the things that are associated with IBS. With most people with IBS, they do have psychosocial factors that have a great influence upon their pain and their abnormal visceral perception. They also have altered gastrointestinal motility. Oftentimes it's either too fast, resulting in diarrheal type defecation, or it's way too slow, and has symptoms of constipative type IBS. Oftentimes, what sets off IBS can be a history of some sort of infection or some sort of food allergy or upper respiratory allergy that can tend to happen. There is there's a gut-brain axis in which that if the brain is perceiving stress, that can also irritate and increase the abnormal visceral perception and pain, as well as change the altered gastrointestinal motility, making it worse, either towards constipation, slowing down, or faster towards diarrheal and speeding up. This particular functional bowel disorder has a lot of hallmarks of food allergies along with it. Although all forms of functional gastro disorders have some sort of luminal distension that occurs with it, in IBS, the luminal distension gives abnormal visceral sensory input to the individual. So when we look at this here, we talked about diet a minute ago. Foods such as fructose and fructans, lactase, galactans, and polyols all tend to be either osmotically very active or rapidly fermentable. And what happens is when you have the osmotically active foods coming in, it increases water delivery into the system, which increases luminal distension. You can get motility change and bloating from that. When we have foods that are rapidly fermentable, we can increase gas production, which increases luminal distension and gives a lot of problems with pain and or gas, wind coming from the anal rectal region. As I talked about earlier, irritable bowel syndrome has lots of pieces and parts to it. It has classifications that will cause it to be either diarrheal or constipative, or sometimes it's mixed, and it can swing back and forth. Diet has a great deal to do with it, and we'll talk about the Fructans diet or the FODMAP diet in class. A lot of patients have stress, and the stress will, most everybody has stress, but in particular, patients with IBS, stress really tends to increase their symptoms and exacerbate their symptoms. Exercise can really tend to improve all of this, and certainly women more than men suffer from IBS type symptoms. So how do these people present? Usually they have kind of colicky abdominal pain, basically mostly over the lower abdomen. Always tends to be relieved by defecation for the most part. They complain of a lot of abdominal distension, and they say that it worsens throughout the day. So they start off in the morning pretty good, but by after lunch they're pretty uncomfortable. They have altered bowel habits. They have defecation straining, or they have urgency, depending upon if they're constipative or diarrheal. There's a lot of rectal mucus, and there's usually a feeling of incomplete defecation and always the need to go. We talked a little bit about the diagnostic criteria. Remember, they need to have recurrent abdominal pain or discomfort greater than 3 days a month over the last 3 months. And it also needs to be associated with 2 or more of the following. The abdominal pain either gets improved with defecation, or the onset associated with a change in frequency of stool. So in other words, if they all of a sudden start becoming diarrheal, there should be abdominal pain that is concurrent with that. Or if it's associated with a change in form or appearance of the stool, such as if the stool becomes loose and liquidy, or if it becomes hard and lumpy. IBS differs from other gastrointestinal functional disorders in that the IBS constipative oftentimes has infrequent pellety stools, and it's usually in association with abdominal pain or pelvic floor pain, particularly around the anal rectal region, called proctalgia. IBS diarrheal is frequent defecation, but it produces very low volume of stool, and it has a lot of mucus associated with it. Mixed IBS is harder lumpy stools and loose, bushy, or watery stools. And then there's an unsubtyped IBS, which is an insufficient abnormality of stool consistent to meet criteria for the above. So there's always somebody who's going to fit outside of the box of the 3 main types of IBS. The supporting features of IBS, again, symptoms greater than 6 months, as we discussed previously, but also previously medically unexplained symptoms, frequent consultation for non-GI problems, and it tends to be that stress tends to really worsen the symptoms. So these are people that have gone to the GI doc and have not really found any kinds of signs or symptoms of serious disease, but then they also are having frequent consultation for other non-GI problems such as migraines, fibromyalgia, chronic pain, joint pain, and many different other things. Some of those non-GI related problems can be heartburn, fibromyalgia, chronic fatigue, no weight loss, unremarkable physical exam, but abdominal tenderness is usually present. And if they tense the abdominal wall, local tenderness is associated with abdominal wall pain, whereas it lessens visceral tenderness by protecting the abdominal organs. This is referring back to the Carnett test. We learned this in pelvic 2. We'll review it in pelvic 3. There are many things that will let us know about IBS, but there are very few medical tests that are required for patients who have typical IBS symptoms. One of the things they do look at is they look at their blood count. Is it normal? Are they abnormally bleeding anywhere, which can indicate something serious in the GI system? They also look at fecal calprotectin, and the sigmoidoscopy, and all of these things are generally very normal in IBS. When it becomes a little bit alarming is if they're suddenly getting an onset of abdominal pain and changes of stool if they're over 50 years. In the male, you're really looking at history of colon cancer, but also female as well. Do they have weight loss, rectal bleeding, anemia, or nocturnal symptoms? In other words, are they being woken up at night with this? That's when we need to kind of not write this off as a typical IBS experience, but really investigate further. Medically, with older patients and rectal bleeding, um, the, these patients usually undergo a colonoscopy to rule out malignancy or inflammatory bowel disease. An IBS diarrheal to exclude organic GI disease, oftentimes they'll look to see if they have any microscopic colitis within their intestinal system. They also look to see if they're lactose intolerant. Do they have bile acid malabsorption? Do they have celiac disease? And some of the other things that you see listed. IBS management needs to be multi-directional or multidisciplinary. One of the things that needs to occur, of course, is to reassure the patient that there's no signs and symptoms of serious disease. But we want to also treat these people as if that they were a persistent pain patient or somebody with a central sensitization. So we need to look at all the different inputs to the system to begin to help them resolve some of their issues. One of the things that works really well is an elimination diet. The first thing they like to eliminate is lactose. They also suggest a wheat-free diet. Make sure that they're not getting an excessive caffeine intake or artificial sweeteners such as sorbitol. All of these have been known to really irritate and affect the symptoms of IBS. If the symptoms resolve, that's fantastic. Then they can really manage it with their diet. But sometimes the symptoms will persist. When the symptoms do persist, with IBS diarrheal, one of the things that they will also add to the dietary changes is to avoid beans. The next thing is if symptoms continue to persist after that, then they look to antidiarrheal drugs as you see listed here. If the symptoms continue to persist beyond antidiarrheal drugs, then they look at amitriptyline to help them begin to settle down and really get some restorative rest at night and to allow their gut to rest and go through normal digestion. If symptoms continue to persist beyond that, some of the medical management is to go into relaxation therapy, biofeedback, and or hypnotherapy to help really mediate the stress response. For persistence of IBS constipative type category, beyond the dietary changes mentioned above 2 slides ago, you also want to look at maybe perhaps a high roughage diet that can really help them begin to move things along a little bit better. Some of the things they look at is psyllium and lactulose to maybe help. If symptoms continue to persist there with abdominal discomfort, then we look at relaxation therapy, biofeedback, or hypnotherapy. As I explained earlier, pain and bloating are oftentimes symptoms that go along with IBS. And so maybe they'll look at using some sort of spasmolytic drugs. One of the biggest things that they like to use is peppermint oil. But you may need to get enteric-coated peppermint oil pills if they have a lot of issues with reflux, because the peppermint oil can be quite irritating to that. Again, with pain and bloating, they'll look to maybe doing amitriptyline to help them rest better at night. Also probiotics, because there may be a lot of bad bacteria or different bacteria overgrowth from fermentable foods that they've been eating and have not been able to process well. Again, we talked about some dietary changes that are also the same with IBS. Excluding wheat and dairy products are the first 2 to go. Again, as symptoms persist, we need to look towards the other factors that are part of that central system windup. Some interesting findings around vitamin D and IBS are starting to surface. There was a recent study that reported a high dose of vitamin D3 helped improve IBS symptoms. But how? Why would that happen? Well, one of the things that they're beginning to look at is they're thinking that perhaps there's parts of IBS that might be a little bit of an autoimmune disease, and probably because people are eating things that their body really can't handle, and so they're developing a lot of antibiotics around that. Vitamin D could be something that is important for changing the intestinal mucosal barrier which doesn't tend to function very well with people with IBS. When we consider people who have functional bloating, we need to kind of understand what that is. It's generally a recurrent sensation of abdominal distension that may or may not be associated with measurable distension, but it is also not part of another functional bowel or gastroduodenal disorder. So we can have people who have functional bloating stand alone without visceral hypersensitivity and or maybe without changes of defecation that you would see as hallmarks in IBS. Functional bloating is about twice as common in women as it is in men, and it's often associated with menstruation. So there might be an inflammatory component to that, thinking about how hard the uterus works and the hormonal changes that goes with it. It typically worsens after meals and throughout the day and tends to improve or disappear overnight. It can be associated with IBS. You get both increased intestinal gas accumulation and maybe abnormal gas transit. So oftentimes they will complain about feeling the need to pass gas more often throughout the day. So functional bloating symptoms tend to come on as the day increases and tends to come up if they ingest specific foods. And I would suggest that oftentimes those foods are foods that are like lactose and wheat, such as pizza, hot dogs, bad food that have a lot of processed food to them and or sugar. They oftentimes will be accompanied by excessive burping and or gas. These people also could show diarrhea, weight loss, or nutritional deficiency. And if you find that, that should help you send them off for another look from the GI doc. In order for somebody to be considered as a functional bloating category, they must include both of the following: a recurrent feeling of bloating or visible distension for at least 3 days a month in the last 3 months, and also an insufficient criteria for a diagnosis of functional dyspepsia, IBS, or other functional GI disorders. Interventions for functional bloating are always associated with IBS or constipation, and if the symptoms of IBS or constipation are improved, generally the functional bloating begins to change as well. If bloating is accompanied by diarrhea and worsens after ingesting dairy products, fresh fruits, or juices, further investigation or a dietary exclusion trial is worthwhile. Moving along and getting into disorders that we actually can diagnose that are different from functional gastrointestinal disorders. The first one I want to talk about a little bit about is celiac disease. And basically the hallmarks of this is malabsorption from damage to the villi of the small intestine. It's generally an inherited disorder, and it is an autoimmune disorder. It shows that they have an intolerance to gluten, and oftentimes accompanying that may be wheat, rye, and barley. Other than the immunosuppressant type piece of celiac disease, there's a couple of ways that they know people can probably get it. One of it is a genetic contribution, and the other is that there's an immunity or a non-immunity to specific antibiotics that are spreading around the blood system when when gluten proteins are being ingested. And so when that happens, certain antibiotics light up, and they know that they have gluten affected celiac disease. People with celiac disease can become quite ill, and before anybody has a dietary change or is trying to help some of their some of their symptoms, they really need to get tested to make sure that they either have celiac disease or they don't. Because if they do, they really need to stay completely away from gluten 100% of the time. But basically, damage to the small bowel includes atrophy and flattening of the villi, which reduces the areas for absorption. You get cellular deficiency, and you get some changes in transport across the membranes. Some of the extra intestinal effects are anemia, bone loss, muscle weakness, peripheral neuropathy, endocrine disorders, and follicular hyperkeratosis. So it's not only something that will affect the digestive system, but can have a great effect on our blood, our bones, muscle control, as well as neurological presentations. How do we diagnose it? You can do it with blood tests looking for specific antibiotics. Oftentimes the history is good enough to really be able to discuss if this, the history is really good at being able to evaluate whether or not there is a family history or perhaps a genetic component going with this. They can look at serology tests, and then also one of the things they do is they can do an endoscope and get a biopsy of the small intestine. Moving on to the inflammatory bowel diseases, the first one is ulcerative colitis, and it has many different forms. The first one we'll talk about is ulcerative proctitis, which refers to inflammation that's limited to the rectum. In many patients with this, mild intermittent rectal bleeding may be the only symptom. If there was no history of any bloody stools ever, though, it is not ulcerative colitis. The other symptoms they can have, of course, would be rectal pain, urgency, um, and ineffective, painful urge to move one's bowels. So those can be hallmarks, along with bloody stools or bleeding from the rectum, to help begin to diagnose ulcerative colitis in the rectum. So ulcerative colitis can also present as universal colitis or pancolitis, which refers to inflammation affecting the entire colon, generally the right colon, the left colon, the transverse colon, and the rectum. Symptoms of the entire colon being ulcerative are going to be bloody diarrhea, abdominal pain and cramps, weight loss, fatigue, fever, night sweats, extraintestinal disease. And when people are in the full throes of this, they are very ill. Complications of severe ulcerative colitis are going to be a toxic megacolon, which means the inflammatory complications extend beyond the submucosa into the muscularis. The colon dilates and produces a toxic patient. So when they get fever, hypotension, electrolyte disturbances, muscle changes, and abdominal distension. It can also result in a perforation and strictures. Oftentimes patients will develop strictures between 5 to 25 years after their diagnosis. So as something dies because of the lack of the blood flow and the inflammatory process, the strictures are really very difficult to deal with because they can result in bowel blockage. The family partner in inflammatory bowel disease is also Crohn's disease, and there's three main patterns of distribution in Crohn's disease. In one, it's 40% of the ileum and the cecum, 30% confined to small intestine, or 25% of colon only. So you can have various degrees of Crohn's disease throughout the GI system. Crohn's is also highlighted by diarrhea, abdominal pain, obviously from serosal inflammation, and from intermittent partial obstructions. The weight loss here can be up to 20% of the body weight during a exacerbative period. And there's obviously malabsorption and decreased oral intake that goes with it. Relapsing and remitting symptoms are the hallmark of Crohn's disease and can sometimes just spontaneously improve in about 30% of the cases. In Crohn's disease, the thickened bowel wall with secondary narrowing of the bowel lumen occurs. You can have skipped lesions, which are a characteristic feature. They call those cobblestones. Oftentimes the transmural thickening and ultimate fibrosis produces kind of a string-looking effect that you can see on CT scans. Complications of Crohn's includes mucosal breach to the intestinal wall, abscesses, and fistulas. So it's not unheard of with Crohn's and ulcerative colitis to have extraintestinal manifestations. Oftentimes we can have something called colitic arthritis. You can have sacroiliitis or inflammation of the sacroiliac joints. Ankylosing spondylitis is a common occurrence in men of Norwegian descent. Problems with the liver, bone disease, avascular necrosis of the hips and the shoulders, and oftentimes renal stones in the ureters. You can have UTIs and many of the other things that you see here listed. The most alarming of all is the incidence of DVTs and PEs and thromboembolic events in people with IBD. There is no one single test to diagnose inflammatory bowel disease, but historically the two main tests that they use are colonoscopy and small bowel function tests. Lab studies have become an additional tool as well, particularly looking for anemia and those types of things that go along with IBDs. There are some lab tests that are able to help you type out the different types of IBD. So there's a couple of tests that will help be more specific to ulcerative colitis, and other tests will be more specific to Crohn's. None of them have the best sensitivity though. How do we medically manage IBD? It can be divided into an acute exacerbation, a maintenance of remission, and/or a surgical solution for those parts of the intestine that are lost due to the inflammatory process. Some of the therapies used for inflammatory bowel disease were conventional therapies that included immunosuppressants and corticosteroids. They didn't have the best possible outcomes. They've moved towards biological therapies, which have given remission rates, reduced hospitalizations, lower surgery rates, and helped fistula closures more often. Some of the things that they found with these is that they just have better long-term results. Most of these biologic therapies are antibodies that are inhibitors for tumor necrosis factors. So they inhibit that type of response in the autoimmune, and thus makes it easier for the system to begin to heal. So the biologic therapy is used to block the messenger of inflammation. And we talked a little bit about the tumor necrosis factor. And here are some of the examples of the types of antibodies they use that are injectable for the TNF blocking treatments. So when do they know to use when do they know to use surgery? Usually the absolute indications are if you've got a hemorrhage or perforation, cancer, dysplasia, or they're just unresponsive to acute symptom management. Relative indications become more prevalent with chronic intractability, steroid dependency, growth retardation, or symptom complications associated with ulcerative colitis.